So we'll peel that back, show the temporalis muscle, and some injectors would like to go deep to the temporalis muscle. If you do that, a perpendicular injection is the best. What you don't want to do is inject underneath the deep temporal fascia, but on top of the muscle, because if you do that, and you can see where my needle comes right now, it's continuous with the midface. And so the fat that is in here is really buccal fat. It's the superior extension of the buccal fat. And you can see where I've stuck that needle right through. It's continuous right underneath the zygomatic arch into the midface. And the reason that that is important is if you get in that layer above the temporalis muscle, you will waste product, and you'll have product that leaks into the midface, and it really won't do what it's designed to do. That's to elevate and to fill out the hollow temple. So we've gone down to the last layer of the temporal fossa and cut through that. But to orient you, here is layer 3, the superficial temporal fascia, also called the temporoparietal fascia. Here is layer 4, the deep temporal fascia, or actually layer 5. And then we've cut through layer 6, which is the temporalis muscle, and we were showing the temporal bone. Now this bone actually can be perforated if somebody's too aggressive with a needle. So if you go down onto the bone, you've got to be a little gentle with your injection. Most injections in deep to the temporalis muscle actually get into the muscle itself. They're not entirely deep to the muscle, they're mostly deep to the muscle. We have to know that the depth of the fossa, it is the deepest. It's like a swimming pool that is uneven. This is the deep end right behind the conjoined tendon. This is where it's the hollowest, and then it fills out a little more. This is the shallow end. So it's like a pool, but this is the deep end right in here, and this is where we want to fill it the most. We've created a superiorly based skin flap. The skin of the forehead is fairly thick with a dense subcutaneous tissue which attaches the skin to the deeper elements in the forehead. If we look at what the surface anatomy would be, on the surface we can see muscles that are oriented like this, the corrugator supercilii, which we will see later, the procerus muscle, which is midline, and the paired frontalis muscle on each side of the forehead. We're going to talk about these muscles in a little bit. If we raise up the skin, we can notice that there are a lot of subcutaneous vessels which can be seen immediately beneath the skin. As we look, we see the supratrochlear, the supraorbital vessel on each side. On this side, we see only the supratrochlear. Coming from the temple in this side, we see the superficial temporal artery. All of these vessels run in layer 3. Layer 3 is the superficial fascia. In the forehead, the superficial fascia is called the galea aponeurosis. In the temple, the superficial fascia is called the temporoparietal fascia. We can look here and see the frontal branch of the superficial temporal artery. There is also more posteriorly a parietal branch of the superficial temporal artery. Then there are branches that come from the internal carotid artery, the supraorbital, and the supratrochlear. Now, what is interesting is there are intricate anastomoses between the external carotid-derived superficial temporal artery and the internal carotid artery-derived supratrochlear and supraorbital. If the camera moves in for just a little bit, we can see that the frontal branch of the superficial temporal artery has an anastomosis with the supraorbital artery. And this I see in almost every cadaver, some branch of this. But if we look up higher, we see that the superficial temporal artery also anastomoses with both the ipsilateral supratrochlear and even the contralateral supratrochlear. The reason that this is so important is the complications that occur if we put one of the fillers and we get it into a vessel certainly can be vascular compromise to the skin, but they also can be blindness. It's commonly thought of if you inject something into an external carotid branch, and this is the superficial temporal artery, one of the terminal branches of the external carotid artery, the other terminal branch being the internal maxillary artery. If we inject it into an external carotid branch artery, that we can't get this into the eye. That's not really true, because these anastomotic branches can go intracranially and get into the posterior aspect of the orbit. This is a little bit scary and a little bit dangerous. So anything that is injected into the temple, into the superficial temporal artery, can get an anastomose with internal carotid branches and go into the eye and potentially cause blindness. This is the superficial anatomy of the forehead. In the forehead region, the vessels that run on the superficial surface of the frontalis muscle are encased within fat. We've removed the fat from the superficial surface of the frontalis muscle. You can see the edge of the frontalis muscle as it starts here. There's an aponeurosis behind it. There's actual muscle belly here. If we lift up some of this fat off of the front of the muscle, we see the edge of it, which it becomes slightly dehiscent in the midline. We're staring at the edge of the frontalis muscle. The frontalis muscle is the only elevator of the eyebrow. It pulls the eyebrow up. There are several depressors of the eyebrow. When we want to denervate with a neuromodulator the frontalis muscle, we can denervate it in several spots. We usually do not like to denervate it too inferiorly because we lose some of the inferior elevation of the eyebrow and we can get eyebrow ptosis. However, there are 3 to 4 action potential areas laterally, and we can inject them laterally, starting at the mid portion of the forehead and going superiorly. The frontalis muscle can be injected here and here, here and here, here and here. We do not usually go at this inferior aspect of the frontalis muscle in order to preserve some of the elevator function of this muscle. When we look at the outline of the entire hemifrontalis muscle, in the superior aspect, it attenuates and there is an aponeurosis. This is the edge of the muscle as we've drawn it in. Medially, the muscle belly stops and is somewhat attached. It almost looks like a little bit of a V shape, and there's a separation between that and the left side frontalis muscle. Laterally, the muscle stops at the conjoined tendon, this area that comes up from the lateral eyebrow and is a curved area lateral to the conjoined tendon, but deeper than the one at the level of the frontalis muscle is the temporalis muscle. So the temporalis is here in the temple. The frontalis is in the forehead. These two are not continuous and not even at the same level. This is a more superficial muscle. This is a deeper muscle. So the frontalis muscle stops at its lateral border at the conjoined tendon. As we travel inferiorly at the inferior border of the frontalis, it interdigitates with some fibers of the sphincteric orbicularis oculi muscle. So the orbicularis oculi, which encircles the eye is at the relative same level as the frontalis muscle. That's the inferior extent of this muscle. As we look at the layers in the forehead, we see the skin, layer 1, the subcutaneous fat, which has been removed, layer 2, layer 3, which is the galea aponeurosis and the frontalis muscle, and we're staring at the frontalis muscle. Beneath this are layer 4 and 5, the loose areolar tissue and the periosteum of the forehead. Running in layer 3 are the supratrochlear artery and vein and the V1 that runs with this. Also, the supraorbital can be seen here. That is anastomosing with the superficial temporal artery that comes out of the temple. If we lift up the galea aponeurosis and the frontalis muscle, and we see the edges of that muscle, if we lift this up and lift it forward, we can see on the back the posterior lamina of the galea aponeurosis, and we can see a branch of the superficial temporal artery which runs in this layer, and we can also see the back of the supratrochlear and the supraorbital arteries that run in this layer. We can peel that down, and this exposes the inferior aspect of the forehead and the brow. As we're looking down, we see the beginning, the origin of the corrugator supercilii muscle. This is layer 5, the periosteum. Connecting layer 3 with layer 5 is loose areolar tissue. As we look at the connection between layer 3 and layer 5, the loose areolar tissue, and we look down in the inferior aspect of the forehead, several things can be seen. First, we're staring at the periosteum. Within this periosteum are several small vessels, and there are some vessels that lay in layer 5. In layer 3, if we continued out into the temple, there's a continuous layer between layer 3, the galea aponeurosis, and layer 3 in the temple, which is the temporoparietal fascia. Deep to that is the loose areolar tissue in both areas. Layer 5, the periosteum, becomes continuous at the temporal fusion line, the superior temporal line, with the deep fascia of the temple called the deep temporal fascia. Layer 5 of the temple, deep temporal fascia, layer 5 of the forehead is the periosteum. They're continuous. As we look inferiorly, we can see the head of the corrugator muscle, which originates from bone. This muscle, or the head of it, is just inferior to a ridge along the frontal bone, that superciliary ridge that makes up the prominence. A little different in males than in females, just inferior to this, filling up the space, is the head of the corrugator supercilii muscle, and this is an oblique muscle which runs in this orientation, starting from bone, going laterally, superficially, and superiorly to insert into the fibers of the brow and into the skin. As we go lateral to the corrugator, we see the roof fat, the retroorbicularis oculi fat, the deep fat of the lateral forehead and brow. We can inject this fat pad to fill up the eyebrow. Filler injections at the mid-forehead are done in this layer, deep to layer 3. Filler injections in the roof are done into the deep fat, which is also deep to layer 3, between layers 3 and layer 5. So we can either, for aesthetic reasons, fill up the mid-forehead or the roof fat. As we lift up the frontalis muscle, which is the only elevator of the eyebrow, we can see the deep structures of the inferior forehead and the medial eyebrow. What we're looking at are branches of the supratrochlear artery and vein, the nerve that runs with that, the supratrochlear nerve, a branch of V1,